Hello, everyone. Yeah, so my name is Nick. I'm one of the R3s, and we are indeed talking about syphilis. I was just mentioning to the folks here, I apologize if there's a little bit of hammering in the background because someone is currently building a little store outside my window. So we'll just kind of roll with it. This is the outline for the talk. So I'm hoping that we will get to talk about the epidemiology and screening of syphilis, the clinical presentation and management, spend some time on serologies, talk about treatment monitoring. And similar to Caitlin, the disclosure that I'm by no means an expert, which as far as syphilis goes, is called a syphilologist. I am certainly not one of those. So our learning goals for today pretty much parallel the outline. So number one, to understand the epi of syphilis and how this informs which patients we screen, the clinical stages of syphilis and the associated treatments, interpret serologies and synthesize the clinical context with interpretation of those serologies, and then finally to know the appropriate monitoring of patients who have been treated. I'll just stop my video here just in case it gets a little spotty. So for the epi, just want to preference this section by saying that just by nature, epidemiology likes to look at generalized patterns of different things. And so, of course, when we have a patient, and particularly with STIs and sexual history, I think it's very important to look at each patient individually, who they are, who they're having sex with, how they're having sex, their sexual behaviors and practices. But nonetheless, that these categories that the EPI provide some very helpful tools to be able to stratify who we decide to end up testing. So the bar graph on the right is from the CDC. It's a bar graph of reported cases of primary and secondary syphilis in the US in 2020 by sexual orientation and HIV status. And I think as you can see, by looking at it, on the left-hand side, we have men who have sex with men, but there's a fairly high prevalence among this group, and in particular among men who have sex with men who are living with HIV. There's also a disproportionately high prevalence of syphilis. I think you'll note too that the y-axis is case numbers, sheer case numbers, and not by capita. So I think that also makes it even further disproportionate. But certainly also cases in women and men who have sex with women and other sexual orientations as well. So what that means is that the CDC recommends that we screen men who have sex with men, as well as people living with HIV at least annually, who are sexually active. And as far as women and men who have sex with women, the recommendation is that we screen if these folks are sexually active and if there's other quote unquote increased risk behaviors or practices or backgrounds. And some of those that the CDC provides as based off of epi studies of folks who have been incarcerated before, people who have engaged in transactional sex, men who have sex with women who are younger than 29, which is a broad category, and I didn't quite fully realize that that was a recommendation as well. And then any patients on HIV PrEP, HIV and syphilis, not uncommonly, are STIs that co-occur. They share similar risk profiles, and yeah, as you can see from the graph on the right, they sometimes run together. And so if someone is at risk for HIV, syphilis is something we should often be thinking about, and certainly if they're on prophylaxis for it, should be screening for syphilis as well. And generally that's done at least every 6 months, although that varies for the individual. And then certainly all pregnant women get routine screening, or at least that's the goal. And then sex partners who have been exposed should be screened as well. This is a bit on the epi by gender identity as opposed to sexual orientation. There's two graphics here, also again, both from the CDC. And I think a takeaway point here is just looking at the graphic on the left that the states that are in purple are the ones that have reported cases of primary and secondary syphilis by gender identity, and that those states aren't very many. And so I think ultimately we just need more surveillance data and to try to get this a little bit better. But the graphic on the right, from the data that we do have, you can kind of see a lot of this is people who are reporting being cisgender, but in the bottom left, we do have some transgender reported gender identities, and that among those different identities, that transgender women have the highest prevalence. And so what this is correlated to is that overall the recommendation is screening at least annually, but it really is, again, just based off of really the individual person, their sexual behaviors, and exposures. This is a graph that's showing the epi now just by ethnicity and race. And certainly syphilis is a disease that disproportionately affects non-white populations. You can see that disproportionately affects Black Americans, American Indians, Pacific Islanders, Latinx folks. And I think this, similar to many other diseases, is probably a manifestation of some of the larger inequities in our society, but certainly I think some of the things that we can consider doing from a clinical and a public health perspective are to improve our public health structures, provide more funding to our public health structures, increase representation of clinicians from these groups, try to improve care engagement by breaking down barriers to care for folks. So needless to say, there's a lot of work that we have to do. Syphilis is definitely on the rise. So the top graph here, all these are again from the CDC, but the top graph here shows, in the purple line, it shows all stages of syphilis, all the way back from the mid 20th century when syphilis was much higher. And you can see it kind of came down. There was a little bit of a peak in the 90s. I'm not quite sure what that was from. And then we hit a trough from about 2000 to 2005. And ever since that trough, syphilis has been steadily increasing. And if we go down to the bar graph in the bottom left, that now breaks down cases of primary and secondary syphilis by sexual orientation. And really all of the different colors representing different identities are increasing, but just wanted to highlight in particular that the one of women in the green has really gone up quite dramatically. And that taking that over to the graph in the bottom right, this is cases now among pregnant women juxtaposed with congenital syphilis, and can see that those cases are all steadily rising and that the two correlate pretty closely together. So certainly a concerning trend. For a little bit of local flavor now, this is the epidemiology and screening within King County. King County has a really robust public health program, and I think they do a lot of good public health work and with syphilis, and they've noticed a very similar trend among women and men who have sex with women, that there's been a disproportionate increase in cases. And they've done some smaller epi studies that have showed that some of the risk factors or common things that they're finding among women that have tested positive are about 30% that were living unhoused and 35% using meth. And so in King County specifically, some of the additional recommendations for screening are to screen people who are experiencing homelessness and to screen folks who are using meth, heroin, or cocaine. So I think I'll just take a pause there. Just make sure I haven't been looking at the chat. Okay. Yeah, any questions so far or comments? All right. So yeah, moving on to clinical presentation and management. So we'll just start off with a question, a STEM here to get the juices flowing. So the STEM is a 25-year-old gentleman who's sexually active with multiple male partners, and he comes to clinic with sore throats, diffuse rash, as shown in the picture here. That also involves the palms and the soles. He doesn't have neuro, otic, or ocular symptoms. The provider orders serologies for syphilis, and what is the treatment for this case? The best treatment. Okay, I'm not sure if this is
We still have a couple people throwing in answers.
Oh, gotcha.
I'm
Cool.
watching it. I usually wait till there's a.
Sounds good. Put my trust in you. All right, so it looks like about half of folks said a single dose of IM benzathine penicillin G, and close to half said one dose for 3 weeks, so 3 doses over the course of those 3 weeks, and then a smaller portion said PO penicillin B for 10 days. Yeah, and so let's move to the next slide. So it would be the first, it would be the single dose of the Pen G, and so we'll go into that in a bit here, but can anyone just either shout out in the chat or verbally what stage of syphilis is this?
This one's primary for him. Lucky guy.
Yeah, so for him it would be secondary because now we're at the stage of the rash. Thank you, Ruth, I think that might have been Ruth. Yeah, so the primary is with a chancre, and then once you get to the stage of the rash and having more systemic symptoms, which might include sore throat, then that's starting to get into secondary. But nonetheless, the single dose of Pen G is going to be the treatment for both of those. So we'll talk about that a little bit more. I really like this slide. This is a slide of the natural history of syphilis from an article. And we're going to break syphilis down into 3 different stages. We're going to talk about early syphilis, we're going to talk about late syphilis, and then we're going to talk about a 3rd category of neuro, otic, and ocular syphilis. And the reason why we're going to break it down into those particular categories is that the treatments within each of those categories is the same. And so it's a nice categorization for clinicians to keep in mind, because it helps me at least remember the treatments. So yeah, the stages, actually, before we go to that one, we can just talk about the natural history a little bit of syphilis infection. So after you get infected with Treponema pallidum, which is the causative agent of syphilis, it usually takes anywhere from 2 to 6 weeks after that infection to develop primary syphilis, which is the chancre. So sort of that classic solitary, painless genital lesion. That's at least the classic description, but it doesn't always happen that way. It's not always solitary. It can be multiple. It can also be in the mouth. It can be painful sometimes. And I think particularly in folks who are co-infected with HIV, that you tend to get some of those more atypical presentations that deviate from the classic with having more ulcers and with it not always presenting in that classic way. And so that's the development of primary syphilis, which is really characterized by the chancre. It isn't always a chancre that patients notice, but nonetheless, after primary syphilis, it usually can be about a month or 2 before someone then develops secondary syphilis, which is really characterized by some of the more systemic symptoms of that maculopapular diffuse rash. That's includes the palms and soles that we get taught, as well as fevers, lymphadenopathy, and some other manifestations. And then there's this other category of early latent syphilis. And all 3 of these, primary, secondary, and early latent, are all early syphilis, which is defined as being within a year of initial infection. And this early latent syphilis is a category that is defined by being asymptomatic. The organism is dormant, so to speak, although it can still be causing issues, just not presenting itself clinically. So move to the next here. So we really just talked about a lot of these. These are the different manifestations of primary and secondary. I think one that I just want to highlight that I think is really interesting and we don't always talk so much about when we're talking about secondary syphilis is syphilitic hepatitis, which manifests itself in this like ALK phos predominant elevation in LFTs, with AST and ALT only being slightly elevated. So I think it's just kind of something that's nice for us as internists to keep in our pockets for our clinical schema. Busted out in a morning report. Yeah, so early syphilis, all 3 of those stages, primary, secondary, and early latent, they're all treated the same way. They're all treated with a single dose of intramuscular benzathine penicillin G. There are alternatives. There's several alternatives, the most common being 14 days of oral doxycycline if someone has a true penicillin allergy. I think with all stages of early syphilis, or rather in particular primary and secondary, it's important to know that this is something that we often clinically presumptively diagnose. We get serologies, but we often are diagnosing this based off of the classic clinical presentation. And that's done for several reasons, but one of them is serologies take some time to come back. Another is that the treatment of a single dose of penicillin, although all antibiotics have implications, that's on the more benign side of things. And then further, this may or may not play in with your individual patient, but whether or not you may see them again too, we also don't want to miss treatment of early syphilis for both the patient's sake and for public health perspective. Whenever you treat someone for early syphilis, it's always just important to remember to request that the partner also gets evaluated and tested, partner or partners, and that you recommend to the patient that they just abstain from sex for at least 7 days or so until both them and their partner or partners have been treated. So just going back for a moment to latent syphilis, I think this is always, at least I always found it like a confusing category. Syphilis has so many different ways to categorize it. So I'm trying to break it down into staying these early, late, and then neurootic and ocular. But there are these different subcategories that are important to know. And latent syphilis is one of them, and it's defined as being asymptomatic. So we talked about early latent syphilis already as being this asymptomatic stage. But there is also late latent syphilis, which is also asymptomatic, but again follows that cutoff of 12 months. And so early latent is that the infection has happened within the past 12 months, and late latent has been over 12 months. How you determine that it's latent syphilis is from really serologies or clinical history. But really you have to have positive serologies, right? Because they're going to be asymptomatic, and this is based off of serologic evidence of infection. But how you determine that it's been within the past 12 months, you can do one of two ways. You can either see that there's been serologic evidence of seroconversion within the last 12 months. In other words, like a negative set of serologies and then a positive set within the past 12 months. Or someone gives you a really clear clinical history of, hey, listen, doc, I got a lesion on my penis 6 months ago, it didn't hurt, and then I got a rash. And now they're coming to you and they've got positive syphilis serologies. That would be a way to say that it's early latent if they no longer have symptoms at that time. Because of course, if they came in when they had primary or secondary, then it would be called one of those. If you cannot prove that it's been within the past 12 months, then it automatically is assumed to be late latent. And so that's an important distinction to make, because that will change your treatment, right? Because we said that the early stages of syphilis and the late stages of syphilis have different treatments. So that's why the distinction is important. So late syphilis, this is now all syphilis that's been, the infection has been present for over a year. And there's really only, there's a couple categories of this, late latent, which we just talked about, and then tertiary syphilis, which has several different manifestations, but that's your cardiovascular syphilis with your aortic aneurysms, coronary arteritis. I think these things have become much more rare with better screening and treatment, and are really things that take years and often decades to develop. And so we don't see them very commonly. Also includes gummatous syphilis, tabes dorsalis, which is a stage that's a late stage of neurosyphilis, and dorsal column involvement that I think we're familiar with. And for all of these stages of late syphilis now, the treatment is the same, and that's now the 3 different doses of intramuscular benzathine pen-G once a week for 3 weeks, again with an alternative for doxycycline. I just want to mention too that with syphilis, it's always penicillin G. So penicillin G, I feel like in boards, they're always throwing in like penicillin D and penicillin K, and it's always penicillin G. Penicillin B is just the oral form of penicillin G, and we never treat syphilis with oral penicillin. And so it's always pen G. And benzathine is just the agent that makes the intramuscular penicillin G long acting. And so if you're using IV penicillin G, you're not going to have the benzathine because you don't need it to be long acting when you're using infusion. So just remember, it's always G. All right. And so the last group that I wanted to talk about with you guys is neuro-otic and ocular syphilis. And from the same natural history, one of the big things that I want to point out, I think one of the takeaway points, is that all three of these can occur at any time during infection, infection of the organism. In this chart here, I think it says 40%, if you can see my arrow here, but after infection, probably some study somewhere showed that maybe 40% of the time the organism migrates to the CNS pretty soon after early infection. Whether or not that migration of the organism to the CNS is causing clinically relevant disease is a different question that may or may not happen. But the point being that it can happen, and it can happen at any time because the organism has gone there very early. So another takeaway point from all three of these too is that neuro-otic and ocular syphilis are actually, they're all distinct entities, and we should think about them differently. Again, we're talking about them in the same group because the treatment ends up being the same, and that's now going to be 10 to 14 days of IV penicillin G being the standard, but they're different. So neurosyphilis is infection of the CNS, the organism, and otic and ocular syphilis result from involvement of the peripheral vestibulocochlear or ocular systems, aka eyeballs. And they may or may not have concurrent CNS infection. And so because they're occurring in different places, our diagnosis and workup of them is also different. And so whenever someone comes in with like clear symptoms that are more neurologic CNS-y of nature, which include cognitive dysfunction, motor sensory deficits, signs or symptoms of meningitis or stroke, and then also cranial nerve palsies, which cranial nerves are peripheral nervous system, but predispose folks to having CNS infection. All of those signs and symptoms are reasons to definitely get a lumbar puncture in someone that has syphilis or that you're concerned has syphilis. If your patient comes in with otic or ocular symptoms, then that necessitates that you get an urgent ENT or opto evaluation. The urgency being that if you have someone that truly does have otic or ocular symptoms, that person can go blind or lose their hearing permanently, and that can happen in the course of even days and weeks. And so it is one of those smaller numbers of ID emergencies, so to speak. And that's something where if you're truly concerned about that being the case, that if you're in clinic, then you want to send them to get that done like the same day. And if you can't get it organized, to even send them to emergency department and let them know that you're concerned for otic or ocular symptoms and that they need an ENT or opto evaluation. All right, so something that seems to always come up with syphilis too, when we're talking about our concern for neurosyphilis, which happens a lot, I feel like in residency, because like a lot of these symptoms are just really common symptoms among people in general. And so who actually needs an LP? The first reason is people that have the same symptoms we were just talking about, specifically the neuro signs or symptoms. So those folks need an LP, and an LP that is normal does rule out neurosyphilis. What we're looking for is we send off a CSF VDLR, which I'll talk a little bit more about. And then we're also looking for pleocytosis, which is just increase in the white blood cell count. VDLR isn't so sensitive, but pleocytosis is. And if they do not have pleocytosis, then they have a very low chance of having syphilis, and they're neurosyphilis, and it's effectively ruled out. So it is useful for that scenario. But I think a question that comes up sometimes is, well, what if they just have isolated otic or ocular symptoms, signs or symptoms, but otherwise everything else is normal neurologically, including a cranial nerve exam? And an LP is not sensitive for otic and ocular syphilis and can't rule them out. And so it's not recommended. And this, again, is only the case where it's isolated otic or ocular symptoms, but because it doesn't pick up all of them, I think something like 90% of true cases of otic syphilis do not have positive CSF studies. Means that it's just not even recommended, and that you're going to be treating with the same treatment of 10 to 14 days anyway. So it's not recommended that we do an LP for those patients. I'm just going to check the chat here. I see some action. To clarify, I think this is the first one. Oh wait, Caitlin says I have ABS smart phrases. Oh, nice. After being treated for syphilis, definitely going to steal those. Yeah, every one of my patients has vague vision hearing symptoms. Agreed. And Sarah, to clarify for tabes dorsalis, does it also? Yeah, it would be neurosyphilis in that case with IV Pen-G instead of the 3 doses. Yeah, sorry, I did categorize that under tertiary. It kind of falls under both being neurosyphilis, but then also neurosyphilis can be broken down into sort of these like earlier versus manifestations that only happen much later, aka in the tertiary stages. Another way in which the categorization is confusing, but it would be neurosyphilis. Okay, so that was reason number 1, neuroscience and symptoms. Reason number 2 is anyone that has tertiary syphilis, which again is becoming less common, but 30 to 40% of these folks have concurrent asymptomatic neurosyphilis, and so they weren't an LP. And in particular, because that changes your treatment, right? The other forms of non-neuro tertiary syphilis are just getting treated with 3 doses of IM benzathine Pen-G versus the neurosyphilis is getting the 10 to 14 days of the IV. So it does change your treatment. And then the third reason is, we'll talk more about serologies, but if you have a patient who you've treated for syphilis and all of a sudden or over time, they have this unexplained increase in their RPR. You can't explain it with, there's no new exposures to syphilis. You really don't think they have a new infection. You think you've treated their primary or secondary syphilis, but the RPR is still going up. Then really you should think about that as like an issue with source control and think about the CNS as something to look for syphilis in that they may have had before. And so it wasn't appropriately treated before with the primary secondary treatment of the single dose. All right, so the summary is who needs the LP? Neurosigns and symptoms, not for people that have just isolated otic or ocular, anyone with tertiary syphilis, and someone with unexplained increase in titers. And just treatment summary here of those different categories. So early syphilis, again, primary, secondary, and early latent syphilis are all the single dose. I didn't mention this before, but treatment of these stages of syphilis is where this Herxheimer reaction can happen, where you get this febrile reaction within the first day. Late syphilis, being tertiary syphilis or late latent, needs the penicillin G 1 dose weekly for 3 weeks, and then neuro-otic and ocular all need the 10 to 14 days of IV. There are some alternatives that are emerging for this, but yeah, we won't get into that. All right, so I just talked a lot about the stages. I think another good place here to maybe pause and see if folks have comments or additions. Yeah, headaches isn't. Thanks, Jordan. Headaches is a good one. It should make you think. So that's common, and that should also make you think of neurosyphilis. All right. Well, we can move on to serologies. So syphilis serologies, I think, are oftentimes confusing. There's two serologies for many cases, and with syphilis, 2 serologies is referring to antibody tests. There's two broad categories of antibody tests that we use for syphilis screening and diagnostics. Those two categories are number one, what we call our treponemal tests, and number two are non-treponemal tests. Treponemal tests are any antibody tests that specifically detect Treponema pallidum, the causal agent of syphilis. And these tests come back as either reactive or not reactive. And UW in particular uses an immunoassay that detects both IgM and IgG. There's tons of different types of these, especially more historically, some of these other ones were used. We're not going to go into them, but you may have heard of like the TPPA, which is treponema pallidum particle agglutination test for the antibody. There's FTA, which is a fluorescent test. And then the other category is the non-treponemal tests. And these are looking for antibodies to lipids that form as a result of cellular damage from syphilis infection. And that's actually what the RPR is an antibody to, as well as VDLR. RPR is the far more common serum test. And the way that will come back is also either reactive or unreactive at first. And then if it's reactive, it's going to reflex automatically, at least at UW automatically, to a quantitative titer. So for screening, the way that algorithms used to work was that they would start with a non-treponemal test like RPR, and then if positive, it would reflex to a treponemal test. But nowadays, what most institutions, including UW, are doing for screening, and so if you order a syphilis screen, this is how it'll go, is it'll start with a treponemal test, in particular that test that looks for the IgM and IgG for syphilis. And then if that's positive, then that will automatically reflex to the non-treponemal test, which is the RPR. And the reason for this switch is that the treponemal test for syphilis antibodies are a little bit more sensitive and specific. And so they become a lot cheaper. And so people have just started to use that first. The way an RPR quant works is, again, if it's positive, it'll get reflexed to be a quant. And the way that they do it in the lab is they'll take some of the patient's serum, they'll put it into a test tube, and then they'll just progressively dilute that out with equivalent amount of saline. And they basically keep testing each of these. They make little wells and they'll test to see if the RPR is reactive in each of the wells until they get to a well that's no longer reactive. And the way that RPR quant is reported is the last tube, for example, if they went all the way out to 1.8 and then 1 to 16 was negative, then the last tube that was positive will be the one that's reported as the titer. So it would be 1 to 8 in that scenario. So that means that the more dilutions needed that you do, and the higher that second number is, then the stronger the positivity of that test, because it took a lot more dilution in order to get it to be negative. I think this test is a little confusing, the way that people talk about changes in the RPR quant, because sometimes people will talk about like a 2 dilution change, or they'll talk about it as in terms of fold of change, like 4-fold, and 2 dilutions or 4-fold is the same. For example, diluting from 1 to 2 to 1 to 4 to 1 to 8 is 2 different dilutions, but a 4-fold increase or a 4-fold change, referring to that second number, which is 4 times higher. All right, so these serologies, I think really just in order to understand how they work, this Dr. Ghanem is a syphilologist at Johns Hopkins, and he does a lot of talks on syphilis, and he had a podcast that I listened to, and he has 4 different rules to understand syphilis serologies that I think if you have those rules, it becomes a lot easier to understand what the serologies could mean. And so I'm just going to go through those with you. His first rule is that both the treponemal and the non-treponemal serologies can both be negative in early primary syphilis. So up to 30% of people that get tested for primary syphilis who have it may be non-reactive. So that's important to remember if someone comes into your office and you get syphilis serologies, treat them, or maybe you didn't treat them for some other reason, that those serologies, they might be negative in 3 out of 10 times. So that's another reason that we presumptively treat primary syphilis, because we can't rely on the serologies and because the serologies take too long. The second rule is that both treponemal and non-treponemal tests can be positive from causes other than syphilis, in other words, false positives. And so for treponemal tests, which again is the antibodies to Treponema pallidum specifically, the false positives can happen from other spirochete infections. Remember that syphilis is a spirochete, so infections like leptospirosis, Lyme disease, yaws, none of which are very common in Washington state, but nonetheless, those are things that can cause a false positive. Actually, severe gingivitis can cause a false positive, and that's because our mouths are teeming with spirochetes. And so if we have inflammation in our mucosa with translocation of spirochetes into the blood, then that can result in false serology tests of syphilis. And then for our non-treponemal tests, aka RPR, the classic false positive is with autoimmune disease with lupus or antiphospholipid syndrome, but other infections, including HIV, can also cause false positives. The third rule is what I think is, if you're going to take home any of these, I think this is a really important one to take home, is that once a treponemal antibody test is reactive, then it's going to remain reactive always, essentially. So this is again the first, this is the first test that we do when you type in syphilis screen into Epic and you order it for your patient. This is the first one that's going to come back. And so that's important to remember, because if the patient's ever had syphilis before, that screen is always going to come back positive. And what this means also is that a negative treponemal antibody can mean one of two things. It either means that they don't have syphilis, or that they could have early primary syphilis because this antibody might not be positive yet. And then finally, his fourth rule is that the non-treponemal antibody tests, aka RPR, can become non-reactive over time in both people that have been treated with syphilis or in people that have not been treated, which is why RPRs can be confusing. So in other words, you have someone that has syphilis, they get treated, that RPR will hopefully go down with treatment, and that's what you're looking for. But also just over years or even shorter amount of time, sometimes that RPR can come down if they haven't been treated. Sometimes that can happen too. So a negative RPR can mean many more things. It can mean that they don't have syphilis, they have early primary syphilis, because it can be false, it can be not positive yet. They could have syphilis that was adequately treated, or they could have had syphilis in the distant past, was never treated, but RPR became negative on its own. Hopefully that make things just more confusing, but I like the rules for thinking just about how these different tests work. And this is the last section here that I have, and this is treatment monitoring. So what happens after you have a patient and you treat them for syphilis, and what are you monitoring? And what you're really using to monitor is the RPR a lot of the time. Of course, you're monitoring patients that you see again for new symptoms, new infections, etc. But you're going to get another RPR, because remember that the treponemal antibody is always going to be positive. That's not as useful anymore, but the RPR is sort of the quantitative titer that we're tracking. And what we're looking for is a 4-fold decrease in the RPR after someone's been appropriately treated. I think it's really important to just remember that in people that have been adequately treated, even in people that have been adequately treated for syphilis, that RPR can remain positive. And this is what's called a serofast state. And so, for example, if someone had an RPR 1 to 64 primary syphilis, you treated them, they went down to 1 to 16, it's possible that they could stay at 1 to 16 for several years or longer. This is different than latent syphilis, because latent syphilis is asymptomatic but implies that it hasn't been treated. But this is just a serofast state where the RPR is remaining positive despite adequate treatment. And so this is why it's so important that if you get someone with syphilis, and you have their serologies, you have an RPR, that having a clinical history and a context in order to help you interpret that is very important. If someone like this went to another state, for example, and they had been appropriately treated and they're now 1 to 16, and that provider had no information, and maybe the patient just wasn't as familiar or couldn't remember, and they checked serologies, they saw it was 1 to 16. Without more history, it's going to be hard to interpret about what to do with that, particularly without another RPR quant. And so that's why sometimes you'll see like ID fellows or other folks in clinic trying to get a hold of King County Public Health. There's like these 2 or 3 people at King County Public Health. I think one of them's name is Ralph. And they just have all this serology RPR data for folks with syphilis, and you can call them and see if they've had a past one to help you understand how to proceed. When we expect to see this decrease in 4-fold titer depends on the stage of syphilis. So for early syphilis, we want to see that within 12 months. With late syphilis or in folks who are living with HIV, right, and people who have had syphilis for longer, or in folks who are immunocompromised, that we're going to see it come down and over a longer period of time, which we want to see over 2 years. And so I think a question is, when do you actually test? Do follow-up serology testing? And I think ultimately there's a lot of factors and there's probably not one right answer. A lot of times 6 and 12 months get cited for someone with early syphilis to recheck, knowing that at 6 months you might not see the full 4-fold decrease. But if you do, then you're done, and you've seen it go down appropriately. And also perhaps that may be done more at 6 months or even earlier if you're concerned that the person may not be engaging in care as well and you just want to check again. All right, I'm going to pause there too and just see if anyone has. Oh, Rolf was one of the other ones who retired. Yeah, I'll have to rely on the other folks. Ruth is saying health departments do keep records. Nice. When you get a positive, you can check the last titer. Yeah, awesome. Syphilis disease investigators are so helpful. They can also tell you, at least in Seattle, what they were treated with. Nice. Does anyone have any questions? Just have a couple. I think we're almost semi-approaching time, but just have a couple practice questions. But any questions or comments?
I think one thing that I need to keep in mind sometimes too is the titers, and let me know if I'm incorrect about this, but like literally it's like people like in the lab like mixing it with stuff and like looking at with their eyeballs to determine the titer, and so it can vary between like 1 and 2 or 1 and 4, and it can go back and forth because it's kind of a subjective test.
Thanks, Caitlin. Yeah, that's a great comment. Yeah, yeah, they wax and wane. I think you're right, by like person's interpretation of it. And then also just because by nature of the test and what it's testing, it can wax and wane a little bit. I've always kind of like heard as this 4-fold decrease is something that is more clinically significant. If you see like these waxing and waning a little bit with 1-fold, maybe don't pay as much attention, but maybe once you're like seeing a 4-fold change. But yeah, this is what that looks like in the lab. Is on the left. This is a positive test with this is the RPR with different antibodies binding to that lipid that forms as a result of the cell damage from syphilis in different clumps. And then on the right side is a negative test where you're not seeing that clumping and the binding of the antibodies. So yeah, you can imagine that between like the first and the second, and just variations of maybe some dishes that might look more like the first one, that you can get a lot of different interpretation. Okay. Any other comments? Thanks, Caitlin. That was good. Yeah. Nikki said you'd think they would have figured out a more easily interpretable test by now. Yeah, agreed. Remind me, do we use 4-fold? Yeah, Jordan. Yeah, so if you see a 4-fold increase, I think the way to think about that, at least that I would think about it, and if other folks have other ways, but I would think about that as a new infection, Jordan, or neurosyphilis. I think that's where the interview with the patient, have you been re-exposed? Is there a chance of that? If so, if there was a clear symptom, maybe we just treat that. But if it's real, no, there's no way I've been re-exposed, talking to them, then that's when you need to start thinking more about, do we not have source control, and is this neurosyphilis, and do we need to do a test or an LP? But yeah, that fourfold mark is where we think about new infection or neurosyphilis. All right. So just a couple, I think I'm just about at time. Maybe we'll just do one of these. So this is just a follow-up question. This is our same patient that had secondary syphilis before. He got treatment with a single dose of iambenzothine Pen-G, and 6 months later, RPR went from 164 to 1 to 32. He's got no new symptoms, including no neuro symptoms, no new syphilis, no new known syphilis exposures. And what is the next best step here? Of course, blocking the question with my poll here, sorry. All right. So we had about a fifth of people say retreat them with a single dose of IM-Pen-G, a little bit of BNC, and then about 2/3 observe and recheck RPR in 6 months. Nice. Yeah, so I think that's probably what most folks would do is at 6 months, if you remember how just from the monitoring, that what we expect in someone that has forms of early syphilis, which includes secondary syphilis, we would expect that it would take sometimes as much as a year in order for that titer to go down fourfold. And what we're seeing with this patient is that the RPR hasn't quite gone down fourfold. It has gone the right direction. They don't seem to have new symptoms. Doesn't seem like they have new exposures. And so overall, this is not an alarming, and if anything, is reassuring that RPR is going down, and that it would be, I think, very reasonable to recheck in 6 months again. And at that time, you'd want to see that fourfold decrease. I think I lied, and I'm gonna sneak in one last question. So this is a 21-year-old transgender woman, they, them, with history of treated primary syphilis 2 years ago, who presented to an established care visit. They have been sexually active with 3 male partners over the past few months without condom use. They don't have DU or other symptoms. HIV is negative. Syphilis screen returns with positive TPPA. It's a treponemal test and non-reactive RPR. So what is the best next step?
While people are answering that question, you'll just see that I threw the link to Intern Core Conference in the chat. Our interns are going to need to break off to join that at 10:40.
Okay, cool.
Feel free to head off and take a minute to use the bathroom, get a drink of water before that starts.
Thanks all the R1 so much for listening.
Nick, we can always send out the slides as well too, so folks have, if there's other questions here that people want to, if there's other practice questions in your slide deck.
Sure. This is the last one. Nice. Yeah. So a smaller amount of folks at ABC, which is variation of different treatments or repeating tests. And then a lot of folks also said discuss HIV prep. And yeah, so in this patient who's been treated with primary syphilis. We know they have had syphilis before, and so a positive TPPA. We know that they're going to have a positive TPPA from having syphilis, and we're not concerned now that that they have syphilis without any new symptoms or positive RPR. And so I think at this point it's reasonable to discuss HIV PrEP with the patient and see if they're interested, just based off of being sexually active and having multiple partners with irregular condom use. Yeah. All right. Thanks again, everyone. While folks are kind of trickling out, Gina, thanks for that question. If the RPR has barely gone down at 6 months, do you do any, like if it's maybe the same or like one up? And yeah,